Lifting heavy, developing force, and increasing strength are all great goals when hinging. However, before we can get to that fun stuff, we really need to ensure that our patients and clients first have a position that allows them to hinge. A lot of times we like to skip to that heavier weights and moving fast, and that's great. I am definitely here for the intensity. We just need to make sure that our patients and clients can truly own that intensity. Now, through anatomical postures and patterns and restrictions, some of our patients don't have a chance to hinge without compensating. So in this video, I want to break down 3 progressions that you can use. So when you are teaching a hinge, you can ensure that your patient or client has the proper position. So then when you add the intensity, they can truly own the movement. To truly understand the why behind the progressions that we'll talk about in this video, we first need to understand what's causing the dysfunction in the first place. And to keep things really simple, as we bring out our pelvis, I just want you to think about a door that's either open or locked. And that's going to really help us start to understand the relationship that muscles have on the pelvis. So when it comes to hinging, we first need to understand the trajectory. The trajectory is that of an escalator. So it's very horizontal in this direction compared to, we could think of like a squat that's a little bit more vertical or elevator-like. So we know that in order to properly hinge, our patient or client has to have the ability to move in more of a horizontal direction. So now that we understand the trajectory of a hinge, let's link that with our door analogy. When the door is locked, that is when a patient attempts to move in a horizontal direction, but they are met with stiffness and tightness in this posterior pelvis. When that happens, they go into their hinge, but they cannot hinge back. They hit a door. So do this for yourself if you want. Go ahead, push back into a locked door. If you need to continue going down, the only way you can do so is by moving vertically like a squat. This is what's happening with our patients and clients that don't have the ability and position to actually hinge. They're hinging back. They're doing exactly what you want them to do, but because they're so restricted back here, they can only get so far, and then because they hit their locked door, they must go in a vertical trajectory. So now we know the trajectory and the reason why our patients can't achieve a hinge. It should be pretty obvious as to what the solution is. All we have to do as coaches and therapists is unlock the door. That is what these 3 progressions are going to do. So as we go through these 3 progressions, keep the why in mind. The why is that we are looking to achieve eccentric length and mobility on this posterior aspect of the pelvis. If we can successfully do that, then it will allow our patient to move out of their posterior pelvic tilt and into more of a position of an anterior pelvic tilt. The anterior pelvic tilt in the correct way is going to allow them to hinge properly in that horizontal direction, so then we can move on to the fun stuff like lifting heavier, developing force, and increasing strength. The first exercise of the progression is a passive piriformis stretch. Now, I'm not the biggest fan of stretching. However, there is a time and place for everything, and really what justifies if someone should incorporate a stretch or not is understand that it is executing and aligning with their goal. So our goal is to create length on this posterior pelvis. So when it comes to our passive piriformis stretch, there's a couple things I want you to consider. First, you probably will have to do more on one side compared to the other. And this is because the body is asymmetrical, and the only way that you know this is through your assessment. So you're going to want to find out which side of the body has decreased internal rotation measurements. Now, if you're not familiar with this or confident with this, I would encourage you to check out the Performance Redefined course, where we have a whole module that goes into lower extremity assessments. The second thing to consider is hip flexion biomechanics. As our patients and clients go through hip flexion, they're actually going through a reciprocating model of external rotation, internal rotation, and then back to external rotation. So from about 60 to 90 degrees of hip flexion, they have an internal rotation bias. And this is also where we see the piriformis switch from an external rotator to an internal rotator. And this is because of the reorientation of fibers. Again, much more detail in the Performance Redefined course. But because of that, that is going to be a limiting factor or constraint for someone that can't hinge. In order to go into a hinge position, we need to achieve that 60 to 90 degree hip flexion mark. So this is why we are targeting the piriformis, and we're doing it in a way that is more dynamic compared to static. So as we go through the passive piriformis stretch, here are some things to consider. When you go up, you're already going to know that one side will probably be tighter than the other. I would encourage you to work the tighter side more than the other side and try to remove the thought and belief from your head that you have to do the same thing on both sides. The next thing to consider is, can we get our patient or client in a position where they can have the contralateral knee straight and the contralateral limb as close to midline as possible. This is going to wind up that ipsilateral piriformis and really increase that stretch. From here, what I like to do is alternating pumps. So I really like to flex the knee on that contralateral side and then extend it and work on periods of moving in and out of it. The biggest thing that I really want you to take away from here is to make sure that your patients know that they don't have to touch their knee to the object that it's on. This is a relatively vulnerable position for the knee, so nothing needs to be forced, and this can be a really tight area for that patient. So take it nice and easy, make sure that they feel comfortable when they are performing the stretch. The second exercise of the progression is a split stance deadlift. Now here's the thing, I don't necessarily need you to get caught up with the specific exercise, but what we're doing is we're moving from a passive to an active state. So what this split stance deadlift is going to do is what we are trying to achieve. That is eccentric length on that posterior pelvis. So you could substitute any exercise into this model. I just want you to think about first doing a passive stretch to get that separation, then move towards more of an active exercise to really capture the motion. Now remember, when it comes to our split stance deadlift, we are looking to open up one side and close the other. So the leg that's back, you are working on shifting back, and when you shift back, that is going to create eccentric length and mobility to start to allow more of that horizontal direction. When it comes to the split stance deadlift, you really want to make sure that your patient or client is truly shifting their hips. A lot of times people overshift, which then typically turns into a squat. So I always like to put a ball between the patient's knees, and that can be a reference to really reach one knee forward as the other goes back. When they're doing this, you want to tell them that the leg that is forward should be moving forward and the back knee barely moves. If the patient or client starts really moving that back leg, then they're going to start going into a squatting motion or hyperextending that knee, which is something we want to avoid. The third and final exercise of the progression is a toes elevated kettlebell deadlift. Now I like this exercise for a lot of different reasons. Let's first start with the slant board. When you go in a toes elevated position, you are putting that patient or client's foot in a dorsiflexed position. What this is going to do is this is going to bias internal rotation really up the whole chain, but you can think of it as biasing pronation and internal rotation at the foot and going up through the tibia and the femur. This is then going to carry into the hips, and that internal rotation position is going to help to establish more length at that posterior pelvis. So if you remember the why behind what we're trying to do, that is exactly it. The second reason I like this exercise is the kettlebell aspect. I like to raise the ground because, again, this is usually a tricky exercise for these types of people. And then I like to position them in front of the kettlebell. Sometimes people position their patients or clients straight above it, but when you go in front of it, it really ensures that the patient or client pushes back. So when you add the factor of the slant board, improving internal rotation and pronation measures at the lower extremity, and then really reaching back in that horizontal direction, you're going to continue to increase the mobility at that posterior pelvis. And then the final thing I'd say about this is nice because this is getting them really ready for the trap bar, the barbell, or those bigger lifts that you are looking to move towards. So I hope you found these progressions useful. The big takeaway that I really want you to get from this video is to always understand the why. Why are you giving your patient or client an exercise? And what does that exercise align with? It should always align with the goal. And then the second thing I would say is that don't get caught up necessarily with just these exercises. Think of the bigger picture. The bigger picture is the categories. All we are doing in this model is moving from a passive, an active, and then a similar or like exercise to the deadlift. And the goal behind all of them is to get them in a position that allows them to hinge properly, and we're doing that by improving the mobility of the posterior lower pelvis.